So without further ado, allow me to welcome our moderator for today's CME, Dr. Kareko, who is a personal friend, colleague, and a great VR surgeon. Dr. Kareko, karibu sana.
Thank you, Dr. Wanjiku. Now, without further delay, I would like to introduce the speaker for the day. He's no stranger to all of us. This is Dr. Peter Situma Wanyama, who's a VR surgeon. He's very active.
Some technical jargon.
Okay. He's very active. He's an active member of OSK and also the Vitreoretinal Society of Kenya. He's currently working in West Pokot. He's a county ophthalmologist there. He also does his VR work at Sabatia Eye Hospital, and he's the proprietor of Samaritan Eye Hospital in Bungoma. So today he'll give us a talk on case reports on Terson Syndrome. So Dr. Situma, karibu sana.
Thank you, Karek, for that introduction. Tell me if you can see my slides.
Yes, we can.
All right, thank you very much. So good evening, everyone, and welcome to tonight's CME. I'm not presenting anything new. When I was told I was to make a presentation, I thought it would be a fantastic opportunity for me to share some of my cases with you. And so I decided to present on this topic. Terson syndrome is not so common. Over the last 3 or so years, I've practiced as a retina specialist in Kenya. I've only seen 4. So those are the ones that I'm going to share with you this evening. So this will be the outline of our discussion this evening. We'll go through a brief introduction, and I will enumerate the 4 cases. Then we'll have a brief discussion, and then the takeaway messages and the conclusion. So why did I choose this topic? Because I've seen a few of them, and I've come to realize that they experience a lot of challenges for them to be diagnosed and also to secure treatment because of the concomitant injuries that they usually carry alongside the debilitation of the eye. So by way of introduction, Terson syndrome describes any intraocular hemorrhage in the context of raised intracranial pressure. So the emphasis here is that hemorrhage in the eye, so long as there's raised intracranial pressure, that's what we classify as Terson syndrome. Initial cases were described in patients who had subarachnoid hemorrhage. And so it used to be that only patient who had subarachnoid hemorrhage and vitreous hemorrhage or something in the eye would be classified as Terson syndrome. But increasingly, it was observed that even patients who didn't have a hemorrhage in the cranium, but had episodes of raised intracranial pressure, would sometimes subsequently develop vitreous hemorrhage or some form of hemorrhage in the eye. And so the definition has been expanded to include any intraocular hemorrhage in the context of an episode of raised intracranial pressure. So about 8 to 19% of patients with subarachnoid hemorrhage tend to also have intraocular hemorrhage, and about 9.1% of patients with intracerebral hemorrhage also tend to have some form of intraocular hemorrhage. Also noteworthy is that about 3% of patients with traumatic brain injury without any form of intracranial hemorrhage also tend to present with intraocular hemorrhage. So in the eye, the hemorrhage can take many forms, the commonest being vitreous hemorrhage. So this one is usually easy to pick on the slit lamp, and the diagnosis is easy to confirm on a well-done V-scan. Through the V-scan, you'll of course notice low intensity echoes spread through the vitreous cavity, and if you tell the patient to move the eyeball from left, right, or up, down, you'll be able to elicit after movements. They can also present with, I don't know why I'm not seeing lines on my screen now. The rest of you are not seeing those. I don't know where they're coming from. Just pardon me. So they can also present with what we call subhyoid hemorrhage. That's the second image upright, in which case you will notice a boat-shaped hemorrhage that covers the blood vessels. So you cannot see the blood vessels because it's above the blood vessels, and it is delineated by only one margin. When you see a similar picture but delineated by more than one line, there's a halo around it, then the hemorrhage tends to be sub-ILM under the interlimiting membrane. In some patients, you may also notice a hemorrhage, but if you study it carefully, you will notice that the vessels are above it. So that tells you that the hemorrhage is under the retina. So that's subretinal hemorrhage. So the pathophysiology of Terson syndrome is not fully understood. Like I said, at initial, the cases were described mainly in patients who have some form of subarachnoid hemorrhage. And so it used to be theorized that it is the same blood that is in the cranium that somehow ingresses into the eyeball. And then that's what you notice as vitreous hemorrhage or something like that. But the anatomical pathway, all of you will agree, from the cranium to the eyeball has not been well defined. It actually doesn't exist. And because of more patients were observed who experienced vitreous hemorrhage or other form of intraocular hemorrhage in the absence of subarachnoid hemorrhage, a new theory had to be thought out. So currently the more accepted theory is that the instigating factor is the rise in intracranial pressure. When that happens, the CSF is then thrust forward by the increase in intracranial pressure, and that CSF, as it moves forwards and in the meningeal sheath around the optic nerve, it causes engorgement of the central retinal vein. So because of that back pressure from the engorged central retinal vein, the distal venules within the retina then rupture. And it's that rupture that then causes the bleeding that you observe either as a vitreous hemorrhage or subretinal hemorrhage or subiodal hemorrhage. So how do the patients present? Typically, they tend to present late. And why? Because they usually come with other attendant injuries. They could be having, like I've stated, the traumatic brain injury or a subarachnoid hemorrhage. And that tends to take precedence because that is more like threatening. And when they're admitted to the neurological units, the neurologist will tell you they need the pupils, observe the pupillary behavior to be able to monitor the patient's recuperation from their injury to the brain. So you may not be allowed to access these patients and put a dilating drops and start doing fundoscopy. Secondly, because these patients also have some degree of cognitive impairment at that time, they may not be able to verbalize their complaints coherently, and so those complaints may not be taken seriously. A study by Gnaraj et al. Demonstrated that typically after expressing their visual complaints, patients still presented late. Those who had bilateral hemorrhages presented about 4.9 months after the first time they complained about their problem, and those who had unilateral issues about 5.2 months. The discussion therein being that those patients are still under intense care, and so the neurologist or the physician was reluctant to discharge them out to the ophthalmologist and so that as to take care of other comorbidities. So when they present to you, then of course the first thing is you need a high index of suspicion. Of course you'll have the story, either they have had hypertension with headaches and loss of consciousness, or they've had a traumatic accident with loss of consciousness, and they may come with a scan. But the most important thing is a high index of suspicion. So any patient with a subarachnoid hemorrhage or a traumatic brain injury needs to undergo an ophthalmoscopy. And the ophthalmoscopy will be able to pick most of the issues I've already highlighted. They may also have a CT scan or an MRI done by the primary physician or a neurologist to try and establish the status of the brain. And those CT scan and MRI will most likely also pick an intraocular hemorrhage. But the gold standard for diagnosing, especially with a vitreous hemorrhage, is the CT scan, because therein you'll be able to differentiate a vitreous hemorrhage from retinal detachment or things like that. So the gold standard remains B-scan. And remember, as you do the ophthalmoscopy, most patients will present with the intraocular changes at the first incidence. But there's a minority that will present initially with a normal ophthalmoscope, rather a normal fundoscopy. Then they develop the hemorrhage later on, maybe 2 or 3 weeks after the primary event, because the intracranial pressure might fluctuate even during admission. And that is what could instigate later hemorrhage. So, if you do a fundoscopy, you find it's normal, and the patient complains later, don't dismiss them. Do another fundoscopy, you might pick something. In terms of management, and in this case, I'm restricting myself to ocular management. If what you find is a mild case, for example, of vitreous hemorrhage, then there's room for conservative observation for at least 3 months. Most hemorrhages will clear by then. But if vitreous hemorrhage persists beyond 3 months, it has been shown that it leads to a lot of complications. Because of exposure to the hemosiderin in the blood, it can cause some form of chemical burn to the macula. And you end up with epiretinal membranes. 15% of the cases, you can end up with macular holes in about 9% of the cases. And of course, blood staying in the eye for so long can also cause ghost cell glaucoma. So beyond 3 months, there's no benefit of leaving that blood. It needs to come out. You need to do a vitrectomy and remove that blood. Before 3 months, it was shown that there was no much benefit of either doing surgery or observing if the blood was going to clear up within 3 months. But some studies have also shown that even if you observe, up to 50% of the cases will not resolve, even after 2 years. Therefore, in some cases, you are forced to do early surgical intervention. For example, if a patient has bilateral vitreous hemorrhage, you not leave them in darkness as you wait for 3 months. You may need to go in early, even as early as 4 weeks or 2 months after the initial event. If the patient is mono eye, of course, you need to intervene early. And of course, if it's a child, because of the risk of amblyopia. So now I'll share with you some of the cases. So the first case was a 20-year-old male college student, who was also a part-time musician, who came to us 3 years after a history of a fall from a motorcycle, in which he sustained injuries to the forehead and bruises to the arms. There was a reported history of loss of consciousness and was in a coma for about weeks, during which time he was admitted in ICU under the care of a surgeon for a period of 1 month. A CT scan then was reported to have intracerebral and vitreous hemorrhage. Unfortunately, I didn't get to see that CT scan. I think the patients felt like the ophthalmologist has no business seeing those images. So when they came, they didn't come with it. So after staying in the ICU for a while, he was discharged to the ward where he remained for another 2 months. During that entire period, he remained confused and incoherent. And even though he was picking up in terms of recovery, his recovery seemed to have reached a plateau. And then he started exhibiting symptoms of depression like withdrawal, becoming incommunicado, and basically his mien was that of depression. This was initially attributed to maybe an aggravation of his brain injuries. And so a repeat CT scan was done. And when they found that not much had changed in terms of his intracerebral hemorrhage, now the neurologists remembered there was a vitreous hemorrhage somewhere, and now the focus was now put firmly on the intracerebral hemorrhage. That's when he was consulted. So when he came, he had those bruises on the head and the face. Right eye, basically, the anterior segment was normal, apart from on the lens, where you would see the posterior capsule was stained with blood. The left eye, the anterior segment was basically, or rather, vision was NPL in the left eye, right eye was HL. In the left eye, vision was NPL. The rest of the findings were normal, apart from a few cells in the anterior chamber. The pupil was fixed, dilated, not reacting to blood. And there was also blood staining on the posterior capsule. These are his B-scan images. On the right eye, well, these B-scans are not the best. However, on the right eye, you are able to see those low-intensity echoes in the anterior vitreous face in contact with the lens, basically. So that's why there was a lot of smearing on the lens. The rest behind it, if you don't see anything, what looks like a membrane here turned out not to be anything intraop. And these were eliciting after movement. So that was a clear sign of the vitreous hemorrhage. On the left eye, it had a V-shaped, funnel-shaped membrane in there that looked like definitely a retinal detachment with very little after movements. Before that, in front of that were features of vitreous hemorrhage, and behind that there were features of subretinal hemorrhage. But because the vision was NPA in that eye, we thought maybe there was also a hint of traumatic optic nerve injury. So with that in mind, the left eye basically there was no intervention because it was already NPR. The right eye, we plan to do aspiration basically, and then clean up the posterior capsule and do vitrectomy to remove the blood. So that's the setup. Unfortunately, I don't have a video of the surgery, but that's the setup basically. So after evacuation, 2 weeks post-op, he came alone and unaccompanied, and we could actually not recognize him. His speech problems, his confusion seemed to have disappeared, and there was no hint of any depression. On examination, right eye vision of 621. Remember, at presentation, it was hand movement, rising with correction to 612 partial. The IOL was stable. The retina had some pigmentary changes at the macula, which maybe could be attributed to the changes due to hemosiderin injury to the RPE. The last time I saw him, which was about a year ago, he remained stable. He was using bifocals, he has gone back to school and was also engaged in his music. He was generally happy, and the left eye was undergoing crisis. The second case was a 45-year-old male, hypertensive, not diabetic. He had defaulted on his medication. He presented, he said he had 2 months prior to coming to us, he had experienced severe headaches culminating in loss of consciousness. At admission, he had been found to have very high blood pressure, and a CT scan he demonstrated a subarachnoid hemorrhage and ocular hemorrhage. He had been admitted to a local referral facility in ICU under the care of a neurosurgeon. So he stayed in ICU for about a week, and then in the ward for another 6 weeks. It was when in the ward that he reported he couldn't see. So he was referred to us for further evaluation and management. At presentation, he came accompanied and he looked visibly anxious and agitated. On examination, the IOPs were basically normal, anterior segment was basically normal. Posterior segment, this scan showed vitreous hemorrhage in both eyes, so we plan to do vitrectomy in both eyes. Unfortunately, he didn't have an HF card, so he put funds together, and so we did the first eye, which was the right eye. Then the second eye, we waited for NHIF to mature, and that was 3 months later. So we did the second eye 3 months later. So right eye intraop, the only thing we found was vitreous hemorrhage, which was straightforward to evacuate. And the left eye 3 months later, intraop, we found he had already developed an retinal membrane and a macular hole. So we had to do an retinal membrane peeling and an ILM peeling, and then tamponade with SF6 gas. 3 months after that second surgery, vision in the right eye had improved from hand movement to 6.6, and in the left eye from hand movement to 6.15. Unfortunately, didn't have money for an OCT, so I don't have an OCT of that left eye. But after seeing him that 3 months later, I have not seen him again. This is about 2 years later. So I assume he's doing well. If he's not doing well, I'm sure he has shown up at the doors of one of my retina colleagues complaining, in which case they can tell me at the tail end of this presentation. The third case, 43-year-old female, was diagnosed hypertensive at the time of presentation. At the time of presentation, he had confusion and sudden loss of vision in both eyes and drooping eyelid of the left eye. He was admitted with an hypertensive emergency, and CT scan revealed intracerebral hemorrhage and intraocular hemorrhage in both eyes. After care by the physician for about 6 weeks, he was referred to the Vitale eye unit and then subsequently to us for further evaluation. So on examination, the right eye anterior segment was basically normal. Posterior segment, he had a vitreous hemorrhage, which was demonstrated on the CT scan and on the B scan. On the left eye, his left eye was in exo. Seemed like only the lateral rectus was free. And there was also complete ptosis. The anterior segment otherwise looked normal. Posterior segment had a vitreous hemorrhage. So because of this concomitant, these findings in the left eye, exo and complete ptosis, we chose to observe the left eye and focus on the right eye. So because from the previous experience, I had now learned that blood stays in the eye for tolling because ERM and macula also. In this patient, we plan to do vitrectomy and peel ILM at the same sitting to reduce chances of that happening. So 6 months after the surgery, right eye vision is 6/6 partial. She's already developing some cataract, hence the partial. Left eye has so far demonstrated no change. The ptosis and the extraocular muscle limitations persist. However, the vitreous hemorrhage in the left eye has significantly reduced, and vision is currently counting fingers 3 meters in the left eye. Remember, the presentation was hand motion. So left eye, we wait. If the ptosis and the extraocular movements improve and the hemorrhage persists, then we'll intervene. We thought if we intervene early and the ptosis resolves and the eye remains in exo, she might just go into the block. So for now, we are just observing. And now this is my last case, a 31-year-old male patient from Lodwar who came with 4-month history of poor vision in the left eye. And that was preceded by a motorcycle accident during which she reported the headache and a brief period of loss of consciousness. The CT scan was done and was concluded to have traumatic brain injury and vitreous hemorrhage. Subsequently, he was referred for surgery for a dissolving left eye. That was 4 months after presentation. The right eye basically was normal. Left eye anterior segment was basically normal, and the posterior segment had vitreous hemorrhage, which was confirmed on this scan. So we also did vitrectomy with internal limiting membrane filling, and post-op vision is 6/6 partial from hand movement. So Terson syndrome may be rare. Like I say, over 3 or 4 years of my practice, I've only seen it 4. However, in patients with subarachnoid hemorrhage, it tends to occur in about 2 to 28%, depending on which studies you look at. The fact that it's rare should not allow it to go unrecognized, because you can see the kind of confusion and mental incapacity that loss of sight can also visit on these patients. And part of the reason why we see very few of them is that any patient with subarachnoid hemorrhage and concomitant Terson syndrome, the outcomes in such patients usually tend to be very poor, 5 to 1. So if a patient has Terson syndrome, in the context of subarachnoid hemorrhage, they are more likely to die than if they only had subarachnoid hemorrhage. And that difference is about 80% difference. However, Terson should be suspected in all patients of subarachnoid hemorrhage, cerebral hemorrhage, and traumatic brain hemorrhage. All those patients should ideally get a fundoscopy done. So when there's room for observation, a more urgent surgical intervention may sometimes necessary in patients with bilateral involvement, mono eyes, or in children. However, even as you manage them, you should be awake to the more serious injuries that they have, in which case you need to work very closely with the physician or the neurologist to ensure that these patients become stable. And then after that, they are not lost along the way, that they're actually referred to an eye unit to use so that you can intervene and help restore sight. So care should not be deferred too long, because we've seen that the mere ability to restore sight can actually impact their neurorehabilitation. We saw in that first patient who came confused, incoherent, incommunicado. 2 weeks after surgery, he was singing like a bird. I told you he was a musician. He actually came and sang one song for us at the clinic, and we were very much impressed. So it's important to always look out for vision in these patients. So in conclusion, a high index of suspicion is key, and vigilance is needed. Fundoscopy for all patients with subarachnoid hemorrhage, intracerebral hemorrhage, and traumatic brain hemorrhage is a must. Restoration of sight can greatly aid patient recovery. Though there's a role for observation, sometimes surgery is needed, and the outcomes of surgery, when needed, tend to be very good. Thank you. It was brief like that. Kareko, back to you. for any questions.
Thank you, Dr. Situma, for that very informative presentation. I'll ask us if we have any questions, kindly post them in the chat section. Wow, interesting. I've only come across 2 cases of Terson syndrome. One patient was a young girl, I think of 13 years. She had a fall from a tree, came in with bilateral vitreous hemorrhages after spending so much time in the hospital. Had NHIF, so with NHIF, you choose one eye. So the eye, unfortunately, we chose, it's a gamble because both of them were dense hemorrhages. So when we did the vitrectomy, we ended up having, or rather, we noticed that she had some submacular retinal bleed, and her vision she never regained her vision. And now since that happened, they were not willing to have the other eye done on cash. So they were waiting for a year to pass for them to do the other eye. The other lady was a patient, the other patient was a lady, middle-aged lady who had, I think had a stroke, came in with bilateral vitreous hemorrhage, and we did surgery, and at least, she had a full visual recovery. So I think early detection and management is key. Thank you for that. From the chat, let's see. Cliff says, awesome presentation. There's a question. Is there a record of increased intracranial hemorrhage in all cases, or is it suspected clinically?
It is usually suspected clinically based on how the patient presents. I don't think we have mechanism locally to measure intracranial pressure, but from CT scan findings or MRI findings, you can suspect that indeed here there was some form of intracranial pressure in case. For example, a patient has a subarachnoid hemorrhage. You know that volume, I think there used to be a law, I don't remember it clearly, that the volume of the cranium does not expand, and everything there has to share space. If one thing increases, one thing has to give way. So if there is blood which is not supposed to be there, CSF has to find its way somewhere, and so it finds its way in those meningeal fibers around the optic nerve. And it's thought that is what causes the pressure to go up, and cause retrograde pressure to go up in the central retinal vein and cause the vessels to burst. Like I said, these are theories. It's hard to prove at the clinical setup that indeed here there's raised ICP and that the hemorrhage is actually consequent to that. But in most cases, there's the setup, the presentation team seems to mirror a case where there's some ICP and then intraocular hemorrhage.
Thank you for that. Asan Mudlai congratulates you for a great presentation. Dr. Inoti is impressed with the singing like a bad part. Maybe you can serenade us after the after the Q&A session with the song that that was performed. A question from Dr.
That's not going to happen. My voice is terrible.
Dr. Wanjiko asks, so how do you determine a mild VH? Because according to you, for a mild VH, you observe. So her question is, how do you determine what mild is?
First of all, if it's bilateral, then we just have to go in. Even if it is, if there's visual compromise. If it's bilateral, the patient cannot see. They came to you because they want to see. Just remove the blood. If it's a child, whether it's mild or dense, you have to go in. The cases that you can observe comfortably is patient who has a unilateral hemorrhage, and you can see some, I think it's grade 3 haze of the vitreous. You're able to see some features of the posterior pole, like you can see the optic disc from afar or the vessels. Then that one you can observe. But if you cannot see the retina, then those are the ones you go in, because you don't know what else is happening behind there. It could be a macular hole that needs to be dealt with.
I agree.
There could be a tear somewhere because it's, for example, in the event of an accident. So those ones, I think you go in and you don't observe for 3 months. You can make out some features of the posterior pole. Those are the ones that I think you can observe.
Okay, thank you for that. Dr. Wanjiku is also asking, since we have some short-acting pediatric agents, can this be used without interfering with the neurologist, the neurologist's, follow-up?
Well, I think there needs to be a collaboration between you and the neurologist. I think you just have to have that discussion and then you decide. I don't think there's a protocol per se of what to do and what not to do. It depends on the patient and it depends on what the neurologist is comfortable with to allow you to do. That's what I would say on that question.
Okay. Hope that settles that. Dr. Walia, great presentation, Doc, and thanks for the reminder, saying he'll get someone to look at his fundus because he had a recent brain injury on the 6th of January. Daktari, we're more than happy to see you.
No, let him come to
Kapenguria, to
yes,
Sabatia.
yes, absolutely.
Sure.
A good tour. A cross-country tour is not so bad.
Dr. Walia, there goes your invitation to West Pokot County.
Yes.
I don't think I understand Prof. Karimurio's question. Reticam.
Non-mediatic.
Prof. Karimurio, maybe you can elaborate a bit more.
Sorry, my question I wrote when you were asking the previous question, where you are saying you are talking about not being allowed to dilate the pupil. And I was wondering, can we use non-mediatic reticam because they are already there?
Yes, they can be used. But I'm sure in this sitting, not many of us have it. Yeah, but if you have it, yeah, it should be allowed. I think that one is admissible, it can be used.
Nice presentation.
Kareko, do you have an non-mediatic fundus camera?
Yes, we do.
Oh, okay. Yeah, then you can use it. But if it's not portable, then you're in trouble still.
Yeah.
So that patient may not be able to sit up for the exam.
From Dr. Maswai and Korir, great presentation. As we wait for people to come up with questions, I was wondering, do you routinely do ILM pills for all your patients with vitreous hemorrhage?
Yeah, after I saw what happened to that patient, the one who did the second eye late, and all those things that happened, nowadays I do routine ILM peeling for all vitreous hemorrhages.
Okay.
Yeah. Especially if it has stayed for long, I just remove it. I think I saw Dr. Jaffa somewhere, our senior. I think he shed some light, some insight. Or any of our colleagues. Dr. Nyango, are you around? Dr. Kibata. They can also give us some insight.
Nyaga, Kitty, I don't think they are.
I think today there's no wailing wall. So everyone, yeah.
I'd seen Dr. Jaffa J as well, but none of the other VR colleagues. I think there being no other questions. Thank you so much, Dr. Kareko and Dr. Situma, for that wonderful presentation. And thank you everyone for joining. Well, thank goodness for the tearing down of the Wailing Wall. I would like to invite Brenda Sigu. Are you there? Please share your slides. Our CME today was sponsored by Novartis, so we allow them 5 minutes to tell us a few things. Meanwhile, I want to remind our members about payment, membership payment. This is what we are using to pay for larger participants, well, members able to join the Zoom meetings. Also a reminder about the upcoming OSK Congress and the COEXA Congress as well. We will keep posting the dates. Kindly begin to plan and register in advance. Brenda, are you ready?
Wow, sorry about that. Sorry, I got thrown out of the chat. Don't know whether we have any other questions.
Oh, while you are away, Kariko, while
Yes.
you are away, Wanjiko, took the liberty to conclude my part of the CME. So
I'm
Brenda,
sorry.
No, it's okay. It's okay. It's okay, Dr. Wanjiko. Since I was not around, I was thrown out of the chat room.
so
Fine.
now,
Situma conclude.
now the parties are taking over. I think our party is done. Thanks for moderating.
Thank you. Thank you so much, Dr. Situma, for that very wonderful, informative presentation.
Asante.
Over to you, Dr. Shiko.
Karibu to our sponsors for the evening. Hi, Brenda. Go ahead. We can see your slides.
Thank you so much. Good evening, all. My name is Brenda Sigu from Novartis, and today I'll be taking you through some of our innovative solutions that we have for the patients you take care of. Next, Mekobo. Yeah. So with regards to your retina patients that Dr. Situma has spoken to, we do have an innovative brand by the name Patizra. Patizra is ranibizumab. Initially, it came by the name of Lucentis, but then we rebranded it to Patizra just to make it more accessible to our patients in terms of financial access. So next. Yeah, so for your diabetic retinopathy patients who come with NMD, DME, retinal vein occlusions, as well as CNV, what we choose or what we give you as Novartis is Patizra because it is the first approved. It was first approved in the year of 2006, and so far it has been used by over 3.7 million patients. And for all these patients, the studies we have conducted on patients who have been initially on Patizra or Lucentis have shown that Patizra is efficacious and it is safe when it comes to the management of all these conditions. Next. Yeah, so in a nutshell, what we're saying about Patizra is if you want the quality of your life, the quality of the life of your patients to improve, what Patizra offers you is that it will give your patients unsurpassed efficacy when it comes to improved burst-corrected visual acuities. It helps them restore their independence, as we've heard from the case patients that have been presented. Most of them lose their independence when they get these retinal issues. So Patizra will be able to help your patients restore their independence, and it also gives them an unsurpassed durability. So you're looking for that agent that will be able to see your patients through their journey while managing the diabetic retinopathies. Patizra is here for you. And right now, we have an access price. So this is one of the innovative brands that you can initiate your patients on with a 3 monthly dosing, after which they enter the treat and extend phase. So, however, as Novartis, we do not only venture in one aspect when it comes to management of your eye care patients. We take pride in taking that in saying that we are a one-stop shop. So we have the external eye disease portfolio, we have the glaucoma regimen, we have the anti-VEGFs as we've seen, and in all these portfolios, what we say is that we offer you as our stakeholders a great portfolio of treatment so that you can be able to improve and extend the quality of lives of the patients you get to see. So when it comes to the glaucoma range, for the next Mikubo. So when it comes to the glaucoma range, depending on the stage where your patients presents, for the monotherapy patients where they just require monotherapy agents as a start, we have Travatan, which is a prostaglandin analog, and it comes with a unique preservative that is polyquad. So it is a back-free monotherapy agent, and it offers IOP reductions of more than 30%. However, when you require between 20 to 25% IOP reduction for those ocular hypertensive patients, we do have Azopt as well as Betoptic. So the advantage that Betoptic also brings on board is the aspect of it being a selective, a beta-1 selective anti-hypertensive. And as for this, then you are safe with the patients who have asthmatic conditions as well as cardio problems. So when you're looking for an agent that is safe for, and you have a patient who to benefit from beta blockers, then we have Betoptic on board for you. However, in the unfortunate event that Travatan is not able to offer the IOP reductions that you're looking at, we have an option of switching these patients to Duotrav, and Duotrav is able to offer IOP reductions of up to 38%. So Duotrav again comes with the advantage of being preserved with polyquad, which is a safer preservative that reduces the incidences of ocular surface disorders. Again, in the event that maybe these are patients who are reacting to prostaglandin analogs, Novartis still has options for these patients. We have Azaga. Azaga is a combination of brinzolamide and timolol, and it's able to offer IOP reductions of up to 34%. So the unique component of brinzolamide that has so far outstood dozolamide in all the case studies is the aspect of its comfort upon instillation. So brinzolamide has a unique pH of 7.2, and this makes Azaga to be well tolerated by most patients who are instilled on it, who are initiated on Azaga as a therapy for management of glaucoma. So sometimes it could reach a point where we feel we've hit the end of the road with eye drops. But again, as Novartis, we recently last year just launched Simbrinza for patients who are on a combination therapy like Duotrav, but are still not on target with their IOP management. So with Duotrav, with patients on a combination of a PGA timolol combo, but who still require an extra IOP reductions, we have Simbrinza as an add-on. So Simbrinza is a unique combination of brinzolamide and brimonidine, and when given as an add-on to Duotrav, it offers an extra 7.7 mm of mercury reduction. So again, it comes with a unique aspect that it is the only combination so far that doesn't have timolol. So again, for those patients where you feel patients who are contraindicated on beta blockers, you can as well initiate them on Simbrinza, and we'll be happy to walk the journey of these patients with you. So when it comes to our glaucoma portfolio, all your patients are covered from Travatan as a monotherapy. Azopt can also be used as an add-on therapy to Duotrav for patients who are not well managed on a PGA combo timolol, on a PGA timolol combo, but still requires just slightly extra IOP reductions. So we usually say Azopt is that extra or hard-working partner for your patients on Duotrav. So this is what we have for you for our glaucoma portfolio, and we truly hope that your patients who are initiated on all these ranges will be able to experience the outcome that you expect with just in regards with maintaining the vision that they present with at your facilities. So thank you, and back to you, Dr. Karoki.
Thank you, everyone. Thank you, Brenda. I think that's it for this evening. The next CME will be on the 14th of next month, and it will be on public health, the RAAB study and survey that has been being done across the country. We'll get feedback on that. Thank you, everyone. Have a good evening.